All right. Hi, everyone, and welcome. I'm Nicole from Swing Care, and I'm so excited today to have Dr. Andrea Chadwick and Dr. Daniel Clauw here with us to discuss fibromyalgia and the current state of fibromyalgia treatment. And before we jump in, I just wanted to give a little bit of background on our guest today. Dr. Andrea Chadwick is Medical Director of Swing Care and is double board certified in Anesthesiology and Pain Medicine. Her clinical expertise focuses on complex centralized pain syndromes, including fibromyalgia. And Dr. Daniel Clauw is Professor of Anesthesiology, Internal Medicine, specializing in Rheumatology and Psychiatry at the University of Michigan. He is also the director of the Chronic Pain and Fatigue Research Center, which was among the first research groups to show the prominent central nervous system contributions to pain and other somatic symptoms in individuals with conditions such as fibromyalgia, interstitial cystitis, idiopathic low back pain, vulvodynia, and endometriosis. He has been at the University of Michigan since 2002, where he's continued his commitment to clinical care and research in overlapping conditions such as fibromyalgia, Gulf War illnesses, and interstitial cystitis, just to name a few. He is an internationally known expert in chronic pain, especially the central nervous system contribution to chronic pain states, including fibromyalgia. So welcome, Dr. Chadwick and Dr. Clauw. And Dr. Chadwick, I'll turn it over to you to continue this conversation. Thanks so much for being here.
Great. Thanks, Nicole. And thank you to Dr. Clauw for being here with us. So I'm going to just start off with an introductory question and something I'm actually excited to hear a little bit about. Tell me what your background is, Dr. Clauw, and how did you start treating fibromyalgia?
So I'm clinically trained as a rheumatologist, and when I was trained as a rheumatologist, the people who trained me told me that they believed that this condition called fibrositis at that time was a real condition, but we didn't know anything about it. And they literally gave me, instead of having a scientific review article, they gave me a one-page article that was written in the Washingtonian magazine, which is like the magazine that talks about the restaurants and things like that in Washington, D.C. It's not at all a scientific journal, but that was about the best article that was written about fibromyalgia at that time. And then once I got out into practice, because I was the new faculty member at Georgetown and located on the totem pole, I was getting most of the new patient referrals, and more than half of the referrals to the average rheumatologist will be for conditions like fibromyalgia if they don't somehow bar the door and say they're not going to accept those referrals. So I started seeing a lot of those patients, and I too began to believe there really was something wrong with them. They weren't making this up, and started to create teams of individuals that could study conditions like fibromyalgia that eventually became known as the Chronic Pain and Fatigue Research Center. I
always love hearing these stories about the kind of journey that it took to get to that fibromyalgia from fibrositis. Tell me a little bit about the type of pain that underlies fibromyalgia. We know there's other types of pain, whether it's nociceptive or neuropathic. Tell us a little bit about nociplastic pain, the currently accepted kind of idea behind centralized pain, and how it relates to fibromyalgia.
Well, it shouldn't have been as difficult as it was to legitimize the fact that some people could develop pain just because of a spinal cord or a brain problem, rather than it being a problem out in the area of the body where they're experiencing pain. Because we've known that conditions like phantom limb pain or post-stroke pain, even headache, are not occurring because there's something wrong in that area of the body where the person's experiencing pain. But it was surprisingly difficult to get the international group of pain researchers to acknowledge and believe that conditions like fibromyalgia were real. And if you couldn't get them to acknowledge or believe that, you certainly weren't going to get, primary care physicians or rheumatologists or other types of individuals to believe it. So a lot of it was, doing the science, using functional brain imaging, quantitative sensory testing, but using more objective measures. And to be fair, some of these techniques like functional brain imaging only became available, about 20, 25 years or so ago. So until then, there were a lot of conditions of the brain that were due to dysfunction of the brain that were very difficult to diagnose because we didn't have a research tool that could peer into the brain of a living, awake human being. So anyway, it was the combination of some new research tools like functional imaging becoming available, with I think, a lot of groups like ours that really became sort of committed to studying those conditions because they otherwise didn't. These people were often very stigmatized. They weren't believed. And again, if you will, they deserved better than that.
Absolutely. And you alluded to the changes that are seen on functional neuroimaging. And for our listeners who are likely fibromyalgia patients or potentially even clinicians, what are some of those changes that you and your group have found within the brain that really show that those underpinnings that legitimize that fibromyalgia?
Well, the first studies used a technique called functional MRI. And in those studies, we gave someone a pressure stimulus. And when we gave the fibromyalgia patients a low pressure, they said that hurt a lot. And until we did these studies, people weren't sure that they really were hurting, but we could actually show in the brain that when we gave these fibromyalgia patients this low amount of pressure to their thumbnail that didn't hurt a normal non-fibromyalgia person, but did hurt them, we could actually see that brain regions we knew were involved in pain processing were becoming activated. So we could infer that they really were feeling pain. So those early studies that our group did that were replicated both by our group and other groups really just sort of confirmed that these people really had something wrong with them. But that was important. That first study that we did, I know for a fact, because we were just down the road from the Food and Drug Administration, that study convinced a lot of people within the FDA at that time that this was a real condition and they should be allowing drugs to be approved for this condition. So even though at some level we're just saying, we know these people aren't making it up, they really are experiencing pain. That was important at that time. And now our group and a lot of other groups have gone way past that to look at the degree to which different brain regions are too connected to each other or not connected enough to each other. Even the size and the shape of the brain changes over time as people have chronic pain because of what we call neuroplasticity. But now I'm old, you know that, Andrea. And when I was trained as a medical student, we thought that the brain stopped growing and when people were like 20 or so, and now we know for your entire lifetime it's constantly modeling and changing, and we call that neuroplasticity. And we know that when people develop those changes, it's not irreversible, but it's probably a little bit more difficult to reverse things after you even change things like the size and shape of your brain or the way your nerves in the periphery are working as a result of having chronic pain. So you have to sort of retrain yourself, rehabilitate yourself as part of, getting better from these kinds of pain conditions.
Well, and I really like that concept of the dynamic nature of this condition. And tell me a little bit. So you had mentioned that the patients with fibromyalgia would feel a pressure sensation as painful. Many patients with fibromyalgia were diagnosed with fibromyalgia with a tender point examination. Can you talk a little bit about how the diagnostic criteria went from a tender point examination to what's the currently accepted criteria?
Yeah, so I think I was largely responsible for that because tender points were a good idea at the time because we were trying to get at when someone is tender throughout their entire body, that actually does sort of suggest that maybe the fundamental problem is that all the nerves throughout their entire body are more sensitive rather than them just having a problem, with pain in one or two areas of the body. So that wasn't a bad idea to incorporate tenderness into the definition of fibromyalgia. But what we didn't know at that time was women are a lot more tender than men. And any criteria that look for a certain amount of tenderness would be skewed towards diagnosing mainly or sometimes almost always women. and that allowed conditions like fibromyalgia to be even further stigmatized. I mean, and again, the classic thing was the older male physician being patronizing to the younger female patient. And when other men started to show up with fibromyalgia, and all of a sudden the criteria changed and eliminated tender point counts, and now it's a 2-to-1 female to male ratio in fibromyalgia, not 9-to-1. And that is really good for the men who have conditions like fibromyalgia, because otherwise they were going undiagnosed. And again, in my early era of training, you can tell me whether this is still the case. A lot of those men, the problem they ran up against were surgeons thought that their pain was coming from their back, and these were the people that got 7 back surgeries before someone threw up their hands and said, well, maybe it's not a back problem. And a lot of these people with what I labeled failed spine syndrome, failed surgeon syndrome. It's that you should have figured out after a couple surgeries you weren't going to help the person. But be that as it may, your work is suggesting, that a lot of those people really had more of a fibromyalgia pain condition. But if you were a male in that era, you weren't, that wasn't like a viable diagnosis.
Absolutely. I mean, it really underdiagnosed them. And as you're suggesting, a lot of people, if they're not diagnosed and they have pain in certain regions, they're going to end up in physicians' offices and potentially be offered treatments that aren't focusing on that real problem, which is that underlying nociplastic centralized pain. I did want to ask you, just because of your training as a rheumatologist, to explain a bit about how fibromyalgia coexists with autoimmune disorders like lupus or rheumatoid arthritis, and whether it's directly related to the underlying rheumatologic condition, or if you feel like they can happen in parallel. I think our readers or our listeners may be interested to hear about that connection from a rheumatologist.
Okay, so it's a little bit of a complicated question to go through, but first of all, some of the people that develop a condition like rheumatoid arthritis would have had things like fibromyalgia to begin with, because these are just common conditions. But we know that if you look at a group of people with any autoimmune disease, whether it's rheumatoid arthritis or lupus or ankylosing spondylitis, that a much higher proportion of those individuals will have fibromyalgia than you would see in just the general population. And some studies that involve colleagues of ours like Yvonne Lee have shown that about in the year of a rheumatoid arthritis patient is first diagnosed with rheumatoid arthritis patient is first diagnosed, only about 6% of them will have fibromyalgia, which is about the prevalence in the general population. But over 3 to 4 years, about 20 to 25% of them, an additional, again, 15, 20% of those rheumatoid arthritis patients will acquire a different kind of pain, i.e. centralized pain or nociplastic pain that needs to be treated in a different way. And that still remains a struggle to teach the people to take care of those people with autoimmune disorders, that, maybe up to a third of their patients with lupus or rheumatoid arthritis or an autoimmune disorder may have developed fibromyalgia as a secondary type of pain, but often it's not secondary. Often that becomes the primary type of pain after that person is successfully treated with anti-inflammatories or biologics or disease-modifying drugs. We see that a lot of patients with autoimmune diseases still have a lot of residual pain, even though we've gotten rid of their inflammation. So we think that's an important subgroup of patients with fibromyalgia, those that have that sort of superimposed upon autoimmune disease, that it happens commonly superimposed upon things like sickle cell disease. Mm-hmm. So almost any chronic pain condition, the longer people have had it, the more likely it is to centralize in a subset of those people.
It's just a very dynamic process, isn't it?
Yep.
Tell me a little bit, you're alluding to the different types of pain. You mentioned inflammation that you see with the different types of autoimmune disorders. Can you explain for our listeners about how knowing the type of pain can influence treatment?
Yes, this is something that our group is really excited about. We think it's sort of the next frontier. And now you're involved in this big nationwide backpack study that's taking this on first in low back pain to try to look at a lot of the treatments that we commonly use, like physical therapy or drugs or things like that, and see if we can better predict, rather than just giving those to every person. And then we know that most of those treatments work, in 1 out of 3 or so of the people we give them to. And that's true of our drug and our non-drug treatments. In the future, we hope to be smarter and we'll use the right treatments in the right people. And the first way in which we think we can do this is by looking at whether someone's pain is much more widespread, fibromyalgia like nociplastic, versus whether it's just involves 1 or 2 areas of the body, where it's more likely to be a problem in those 1 or 2 areas of the body if it just involves 1 or 2 areas of the body. But we think that these centralized nociplastic pain conditions are best treated with non-pharmacologic therapies. Again, because of that, it's important. You use different drugs too, if you know the pain is coming from the brain rather than from the knee, for example. But the non-drug therapies are even more important when you know that you're dealing with pain that's coming more so from the central nervous system.
Can you tell us a little bit about what non-drug treatments work best for centralized pain?
The treatments that have the best evidence base would be things like education, cognitive behavioral therapy, and physical therapy or exercise. So those would be the treatments that we've known forever really can be helpful in conditions like fibromyalgia. They're helpful in every chronic pain condition in which they're studied. What's happened recently is we've come to understand that there are a lot more non-drug therapies that are effective, and a lot of these used to be called complementary and alternative therapies. Now we prefer to use the term integrative therapies because they shouldn't be thought of as being like alternative anymore when the evidence base suggests they work as well as our drugs or some of our procedures that we do on people. They're just a lot safer. So the challenge really is getting a lot of those different non-drug therapies directly out to people, because a lot of people don't have the right therapist in their city or town or community that knows how to give access to these different types of integrative therapies. So and we often find that it's in fact really difficult to find people like yourself that you sort of understand patients with conditions like fibromyalgia and understand how to best use the combinations of drug and non-drug therapies together. Some patients will clearly benefit from some drugs, but again, that also is a challenge to find individuals that are going to help work through some of the evidence-based non-opioid treatments for pain, with the big emphasis being non-opioid drug treatments.
Tell me a little bit about exercise, because I know many patients with fibromyalgia are informed that exercise is really kind of the number one thing they should be going for in terms of treatment therapies. Is there a type of exercise, or can you explain what the research has shown in terms of the type of exercises that are best for fibromyalgia patients?
So you probably haven't heard one of my lectures really recently, because you would know that I don't ever use the E word exercise when I'm talking to patients. I just use the word activity, because it is frightening for patients with conditions like fibromyalgia to even think that they could be quote unquote exercising. That's so far away from the way many of them are having to exist in their day-to-day lives that term is sort of appropriately threatening to them. So I learned a long time ago that if I am in an exam room with someone and I talk to them about slowly, gradually becoming more active, there will be a point at which that amount of activity could be called exercise, but it's going to go over a lot better if I emphasize start low, go slow. It doesn't, the research is strongly suggesting that it doesn't, for cardiovascular benefit, you probably have to reach an aerobic threshold of exercise, and the intensity of exercise may be important. But for the benefits that we see for things like sleep and pain and fatigue, especially, fatigue is for patients out there. If you want an easy win, if you happen to be very sedentary, just get up and walk around for 2 or 3 minutes every hour. And the first symptom that'll get better before your pain is your fatigue. And again, a lot of us came to understand, even people like me that have never had anything like fibromyalgia in my life. I'm very fortunate, but if I sit and do Zooms for 8 hours, I can start to get pre-fibromyalgia. But I think a lot of people started to realize how like prolonged inactivity can be it's tiring and it causes discomfort. And so just start by moving, just start by becoming more active. And there will be a point in which that activity becomes so sustained that someone could call it exercise, but don't focus on getting to a certain amount of exercise, because doesn't seem to really be that important when you're treating things like fibromyalgia.
I agree. I tend to use the word movement and activity in my
Yeah,
clinic as well,
yeah,
because I think just as you said, the word exercise in and of itself, I think there's kind of a connotation that is probably from our culture is, running or biking or doing marathons. And I always tell patients, if your daily movement is getting up and walking around your house for a couple minutes and you slowly increase that, I think that is the focus, is on changing behaviors and getting more activity, more movement. And then if it becomes something that looks like exercise to that person, then that's fantastic.
yeah. Again, people just need to try to keep slowly, gradually increasing how active they are, and don't worry about, there's no like magical threshold of how much you need to be or whatever. You'll notice, that you get better. And the other thing that patients need to be aware of is it's highly, highly unusual that moving or activity causes an underlying pain problem to be worse. Yes, could it lead to a slight worsening of your pain occasionally? Of course. But does it really cause damage? And that's what a lot of pain patients worry about. We know, that they have what we as pain researchers, the long-term kinesiophobia, but people have legitimate fear of movement, because it's like, well, how do I know that's not actually damaging my back or damaging this area of the body? So we as providers need to reassure them that there's, if they start moving more and becoming more active, they're not going to harm themselves. They could, going through some movements, they could translate, increase their pain, but that doesn't mean that it's harm.
Absolutely. I call that the good hurt
Right,
that
right.
comes with movement. Anyone who's moving their muscles more is going to feel a little bit of that good hurt, but you just have to work through it and know that you're doing good for yourself by moving day by day. Tell me a little bit about the other types of non-drug therapies. You had mentioned cognitive behavioral therapy. We know that acceptance and commitment therapy is another form of that. Can you tell us a little bit about how that works for the patients with fibromyalgia that get that type of treatment?
Yeah, acceptance and commitment therapy is one of the newer kinds of cognitive behavioral therapy that's been developed and, again, tested in a lot of different pain conditions, including fibromyalgia, and shown to be effective. It's sort of particularly amenable to almost like an educational or a classroom kind of, where you take people through, different modules, and work on different things. So again, it's probably one of the best accepted but there's now different flavors of cognitive behavioral therapy. This is, if you will, one of the ones that has the best evidence for the most chronic pain conditions.
How does it work? I mean, for the patients out there who might not have heard about cognitive behavioral therapy, can you explain a little bit about what patients can expect with that type of treatment?
Well, so first break it down. Some parts of cognitive behavioral therapy are cognitive, and it works on helping change the way people think about
About their
things.
pain. Yep.
Right. And there's a whole host of ways trying to, turn people from, if possible, from glass half empty to glass half full, working on things like resilience. There's different types of sort of cognitive restructuring that will be part of, again, having people, even some of what I've been doing a little bit of is when, you're trying to move, that pain that you have is not damaging you. But that's working more on people's thoughts and the terms acceptance and commitment is that some of the thoughts they're working on is to get people with chronic pain to accept that they are going to have some pain and that they can still be functional in spite of that.
And commit to the things that they care about, right?
Right, and focus on, and that's another thing, the sort of commitment thing we've gotten smarter in the, last 10 years or so is, we're not going to likely motivate someone to change their behavior radically if we say, well, that will make your visual analog pain scale go from a 6 to a 4. But if we say you'll be able to hug your grandchild or play 9 holes of golf or whatever, so if we focus on the things they really want to do from a functional standpoint, they commit to that and they accept that they're going to, maybe have some pain after they do those things, but that's fine. It's worth it. It's important. And then again, what happens as people, they tend with any of these cognitive behavioral approaches, what you hope to see is that they spiral upward instead of spiraling downward. We're all too familiar as clinicians with the downward spiral that people get into, is that one thing goes wrong and that leads to another thing, and they just go downward. And a lot of what cognitive behavioral therapy is focusing on a rehabilitation approach. It tries to deconstruct things for people, has them work on different things. And some of the things, like almost anything else, it's like your diet is some of the things that is presented to you in cognitive behavioral therapy won't resonate, and you won't like the taste of it and you won't do it. But there might be 2, 3 things out of 10 that really resonate with some, given person. And like one thing can be a huge change for an individual, one aha moment that occurs as a result of going through, 8 hours of cognitive behavioral therapy. No one really knows what part of it is going to help them unless they sort of give it a try and you sort of open their mind to, being willing to acknowledge that there's a lot of things they can do themselves to make themselves better. And there's probably a lot of things they're unknowingly doing right now that are making them worse. And that if they could stop doing those things, they could feel better.
It sounds like a really wonderful approach to having that multidisciplinary care and making sure that in addition to our movement and our activity, which helps our bodies, that the mind is a big player in this as well. You had mentioned something about diet, and I know your group has looked into diet and chronic pain. For our listeners out there, is there any types of diets that are recommended for treating chronic pain or improving chronic pain?
There's a lot of studies ongoing now. We have published a couple studies showing that people that are obese, when they're put on a very low calorie diet, have dramatic improvements in pain, fatigue, depression, and a number of other things. And that happens very rapidly, suggesting that it's something about the diet, not because it's well before they lose much weight.
Interesting.
We're in the process now of seeing whether those same findings are in people that are not obese or overweight. Because again, we were doing these studies in a weight loss clinic at the University of Michigan, where people, were quite obese in order to be eligible for participating in these kinds of programs. So we're trying to see if we think that it might be caloric restriction. There's a lot of data in animal studies that not eating all the time through the day, sort of having 12 or 16 hours during the day when you're fasting, if possible, might be helpful.
Like
and we're trying those kinds of
fasting kind of a situation.
Right. We don't think that the 800 to 900 calorie a day diet that these people in our studies were on is not sustainable, because you can't exercise if you're only taking in that. We want people to
absolutely
be active and exercising. So we're in the process of trying to get studies funded that would be low calorie, caloric restriction compared to what people are normally taking in, so that they do have a negative calorie balance, but they're not losing very much weight. But it does put them in
weight loss.
It puts them into the metabolic state that we think they might need to be in order to have these changes occur.
Interesting. I think that's really wonderful work that you're doing. I know that the patients who are listening are probably going to be very interested to see what results come out of that. And just finally, we've talked a lot about non-drug treatments just now. Tell me a little bit about, we know that there's certain FDA approved agents to treat fibromyalgia. Why are those types of medications, and I'm alluding to things like gabapentinoids, antidepressants, why are those felt to be superior in treating fibromyalgia compared to things like opioids?
Opioids are terrible. They kill people. They don't make this kind of pain better. So let me, again, opioids, there's a lot of evidence that opioids are making a lot of chronic pain patients' pain worse. And we think that especially this fibromyalgia-like pain is often or usually made worse when someone takes an opioid rather than, the people focus too much on the addiction problems with opioids. And again, I'm not saying that those are unimportant, but we really are concerned that a lot of chronic pain patients are actually being made worse by continuing to take their opioids.
I think it may have to do with that centralized
right.
that can occur just from taking an opioid.
Right. In one of our studies, by doing brain imaging with carfentanil and PET imaging, we said in it, it looks like the brain of fibromyalgia patients is endogenous opioid-induced hyperalgesia. You know what that means? It means
Yes.
that the person's releasing their own endorphins that are released by their brain, but that actually is involved in the pathogenesis of the fibromyalgia. And the last thing you'd want to do, if that study is correct, is give that person more opioid, because you would expect it to make the fibromyalgia worse and worse. And
like fuel on a fire.
What we see is that, right, I say that all the time in my lectures. It's like throwing fuel on a fire. But it starts so gradually, is that we do see that, for example, when fibromyalgia patients get a surgical procedure and they get an opioid, they're the ones that are most likely to want to continue to take the opioid, because they do get transient benefit in their pain, in their sleep, in other symptoms, even in their stress for the first couple of days. But they don't see that it makes them worse and worse the longer they take it. And as the long run. So anyway, opioids are terrible for chronic pain. They're especially terrible for fibromyalgia. Whereas these other drugs that you mentioned, these other classes of drugs that you mentioned, are specifically what we call centrally acting analgesics, and they're the preferred drugs for people with conditions like fibromyalgia. So those are the drugs that should be used. Opioids, benzodiazepines, other controlled substances, addictive drugs, really don't have any place in the treatment of chronic pain.
And just to kind of wrap up, I know your group is doing a lot of interesting work around cannabinoids. Can you talk to us a little bit about cannabinoids for the treatment of chronic pain, especially fibromyalgia?
Yeah, I think anyone with chronic pain that wants to go this route should try CBD alone and see if it's helpful, because it's not psychoactive, it's not addictive, it doesn't really seem to have hardly any side effects, except it's expensive. If you want to take 100 milligrams a couple times a day of CBD, which is what you might need to take in order to get a benefit. But then again, in a lot of states, people can get access to either medicinal cannabis, i.e. THC, or in our state, it's now entirely legal. And what we're learning about that is, I think people have to be a lot more careful, because a lot of what we're learning is that a low amount of THC works better for pain than what a lot of people are doing unknowingly. A lot of the dispensaries really cater mainly to recreational users, and the recreational users want to get high. And so they have a lot of the really high THC cannabis. That's actually not what the medicinal users should be trying. They should be trying CBD alone first, and then add a tiny little bit of THC to that. So
that's kind of like
anyway,
a high CBD to THC ratio. Yeah.
But they're not, but no one's, when states pass these laws, they don't mandate that physicians or providers get any education. And so the patients don't know what to do. The providers don't want to give advice. Providers are even worried that if they talk about cannabis with their patients, is that somehow can I get in trouble? Because I'm not prescribing it. It's a Schedule I drug. So anyway, it's like sort of the see no evil, do no, and no one knows what's going on.
I call it the Wild West. It's like the Wild West out there.
Yeah, and so most people right now in the general public are not benefiting from cannabis products with respect to improved pain treatment. Let me just say that.
Well, I think I've really enjoyed talking with you, Dr. Clauw, and I know that our listeners will be so thankful for the information that you've shared with us today. And any final thoughts for our patients who may be listening?
Keep moving forward. Really the most important thing as a patient, we get as a patient how easy it is to get discouraged because you've tried this thing and that thing and all sorts of different things. And but the most important thing for you to do as a patient is to be willing to try some new treatments that you haven't tried before. Because the one thing that Andrea and I can tell you for sure is you won't get better if you do nothing. And so that's probably the best advice that I always give to patients is just, we know how hard it is to keep moving forward, keep trying new things, but that's really what you need to do. And eventually we'll get better and better at caring for this, and we'll know better and better things that work. But again, if the patients don't give it a shot and don't try, they for sure are not going to get any better.
Wonderful advice from a very sage friend and colleague. Thank you so much, Dan, for joining us today.
Yep, good talking to both of you. Bye-bye.